The personality disorders. This chapter discusses the disorders associated with the presenting complaints in chapter 17, which you might find helpful to read first. Personality disorders. Epidemiology. There is a lack of consensus about the definition of personality disorders. Although DSM-5 and ICD-10 classification systems have produced definitions, it is rare for a patient with a personality disorder to neatly match it with only one discrete category. It is also unclear whether there is any correlation between diagnostic criteria and the subjective experiences of people identified as having disordered personality. While a number of structured interview schedules and diagnostic instruments have been validated, the level of correlation between these is generally poor. Mental health professionals also remain divided as to how personality disorders should be conceptualized, with some clinicians questioning whether the diagnosis is of any clinical benefit. Patients with personality disorders have a significantly increased mortality, as well as physical and psychiatric morbidities. Relationships with relatives and friends are adversely affected, and there is a strong association between some types of personality disorder and involvement in healthcare and criminal justice services. Community studies have shown the prevalence of any personality disorder to be 4 to 13%, with an increased prevalence in younger age groups, particularly 25 to 44 years, and an equal distribution between sexes. This varies according to the population group sampled. It is higher in patients frequently consulting general practitioners. In GPs, it's about 10 to 30%. Even higher in psychiatric outpatient clinics, 30 to 40%, and higher still in psychiatric inpatients, from 40 to 50%, in self-harming patients, 40 to 80%, and prisoners, 50 to 80%. Okay. Okay, here we have a table that describes the prevalence of the individual disorders and their relevant epidemiology. Note the broad ranges of prevalence from different studies, highlighting the lack of correlation in the current literature. So here we have, for example, for paranoid personality disorder, the prevalence is 0.7 to 4.4. More common in males and lower socioeconomic class, and more common in relatives of patients with schizophrenia. Schizoid personality 0.7 to 4.9, more common in males and offender populations. May be more common in relatives of patients with schizophrenia also. Schizotypal personality 1.6 to 3.9, more common in relatives of patients with schizophrenia. Maybe slightly more common in males. Emotionally unstable, which is borderline personality disorder, 1.2 to 5.9%, more prevalent in younger age groups and females. Etiological link with childhood sexual abuse, most contact with services in mid-20s, 40-fold increase in suicide rate, associated with poor work history and single marital status, often comorbid with depression, substance abuse, bulimia, and anxiety. Antisocial or dissocial personality disorder, much more, it is 0.6 to 4.5%, much more common in men, highest prevalence in 25 to 44-year-olds, associated with school dropout, conduct disorder, and urban settings. Very high prevalence in prisons and forensic settings. Highly comorbidity with substance abuse. While histrionic personality disorder The prevalence is 0.4 to 2.9. Recent research shows equal gender ratio, previously thought to be more common in women. Narcissistic 0.1 to 6.2, more common in males and forensic settings. Dependent 0.3 to 0.6, often comorbid with borderline personality disorder. Avoidant or anxious 1 to 5.2, equal gender ratio, comorbid with social phobia. Obsessive compulsive or anancastic personality 1.2 to 7.9, which is the highest prevalence here, more common in white male, highly educated, married and employed individuals. Okay, so etiology. Different environmental and biological genetic factors are implicated in the etiology of different personality disorders, supporting their heterogeneity. Genetics, for example, monozygotic twins show a higher concordance for personality disorders than dizygotic twins, suggesting a heritability of 30 to 60%. Cluster A personality disorders, especially schizotypal, are more common in relatives of patients with schizophrenia. Some authors have suggested that schizoid and schizotypal personality disorders may be neurodevelopmental disorder, possibly within the autistic spectrum. Depressive disorders are more common in relatives of patients with emotionally unstable borderline personality disorder. Another factor, etiological factor, is early life experience. Early adverse social circumstances such as parental alcoholism, physical or emotional neglect, violence, or sexual abuse are associated with the development of cluster B personality disorders. There is a strong association between borderline personality disorder and childhood sexual abuse, although this is not universal. Various psychoanalytical theories suggest that disordered attachment between infant and their caregivers lead to difficulties in relationships throughout the rest of life, which may manifest as personality disorders. About assessment, clinical features, classification, and differential diagnosis, you can find more of these in Chapter 17. About management. In the past, there has been considerable debate concerning how and by whom patients with personality disorders should be managed. Previously, personality disorders were generally considered to be untreatable. However, advances in diagnosis, psychotherapy, and psychopharmacology have equipped clinicians with a variety of treatment options that can be useful in maximizing engagement with services, reducing distress, managing comorbid mental illness and substance misuse, improving relationships, and optimizing quality of life. Patients with emotionally unstable, which is borderline personality disorder, are frequently encountered in clinical practice, and the most is known about what treatment do and do not help people with this diagnosis. Again, and the most is known about what treatment do and do not help people with this diagnosis. This will, therefore, be the focus of this section. Okay, so let's talk about that. Principles of managing patients with emotionally unstable personality disorder. Patients with emotionally unstable personality disorder should not be excluded from health or social care services because of their diagnosis or because they have self-harmed. A consistent and tolerant approach should be taken. Autonomy and choice should be encouraged, with the patient being actively involved in deciding treatment options and in finding solutions to their problems. An optimistic, trusting, and non-judgmental relationship should be developed. Endings and transitions may evoke strong emotions and reactions in patients with emotionally unstable personality disorder, and as such should be carefully planned and structured to minimize distress. Multidisciplinary approach to care should be considered, as psychological, social, and biological treatment modalities all have an important role. A comprehensive assessment should be made of sources of distress to self and others, thoughts, emotions, behavior, and relationships, other comorbid mental illness, and specific impairments of functioning at work or home. Principles of care in managing emotionally unstable personality disorder. First, be positive, kind, non judgmental. Many are victims of abuse. Be accessible, consistent, and reliable. Do what you say you will do. Encourage autonomy. Facilitate the patient to find his or her own solutions to problems. What's the problem right now? What has worked in the past? What would you like to do? What is an achievable change? Manage transitions and changes carefully in a planned way. Monitor for comorbid mental illness, like depression or substance use. Crisis management. It can be useful to develop a crisis management plan in conjunction with the patient, detailing self-management strategies, sources of support like family, friends, telephone-based services, and details on how to assess emergency care. This should be shared with the patient and other relevant professionals, GPs, assessment and crisis teams. Example crisis plan in emotionally unstable personality disorder. Triggers that might lead to a crisis like losing job, drinking too much alcohol, argument with partner. Things I can do to help myself, like talk to my friend, go to a movie, exercise, get enough sleep, avoid drugs and alcohol. When I should seek help. For example, if I injure myself badly, if I'm having very strong thoughts of suicide, if I feel so bad that I cannot go to work, if my friend advises me to, and so on. Who I should contact and how. Like Samaritans, general practitioner, community psychiatric nurse, crisis team, NHS 24, or best friend or mother, and so on. Short-term drug treatments can be useful to alleviate distress during a crisis. If possible, this should be agreed in advance with the care team and the patient. Drugs with acceptable side effects and low dependence profiles are preferable and should be dispensed in small quantities if there is a risk for overdose. Drugs should not be used in place of other more appropriate interventions. Before admission to acute inpatient psychiatric care, crisis resolution or home treatment teams should be considered. Admission may be necessary if the management of the crisis involves significant risk to self or others that cannot be managed within other services. If possible, actively involve the patient in the decision and ensure that it is based on an explicit joint understanding of the potential benefits and likely harm that may result from admission. Agree the length and purpose of the admission in advance. If the patient is detained under mental health legislation, ensure that this is regularly reviewed and that management on a voluntary basis is resumed as the earliest opportunity. After a crisis has resolved, ensure that the care plan is updated. If drug treatment was started, review this and discontinue if possible. If this is not possible, ensure that it is regularly reviewed to monitor effectiveness, side effects, misuse, and dependency. Short-term management. While treatment of emotionally unstable personality disorder should be considered to be a long-term process, various biological, psychological, and social management strategies can be employed in the shorter term, with the aim of facilitating trust, building a positive relationship with health and social care services, and identifying and alleviating sources of distress. Pharmacotherapy, psychopharmacology. There are no medications that are currently recommended specifically for the treatment of emotionally unstable personality disorder by NICE guidelines. So this is important. However, drugs can be useful to treat comorbid mental illness or to manage cases of behavioral disturbance and suicidal behavior during the more severe phases. In addition, there is some evidence that some drugs may be efficacious in targeting specific symptoms. For instance, antipsychotics may be of some use in treating the pseudo-psychotic symptoms that are sometimes experienced, in reducing agitation and in stabilizing mood. Antidepressants may be useful in treating depressive symptoms. Selective serotonin reuptake inhibitors may help with obsessive compulsive symptoms as well as impulsivity and self-harming behavior. So we have antipsychotics, antidepressants in general, and SSRIs specifically. Mood stabilizers such as lithium, sodium valproate, and lamotrigine may be useful in treating aggression, impulsivity, and mood instability. Benzodiazepines should be used with caution due to the potential of abuse, dependence, and diversion. Psychosocial. Supportive psychotherapy provides patients with an authority figure during times of crisis. Regular contact with healthcare professionals can also provide the patient with a sense of containment. Members of the multidisciplinary team can provide psychoeducation as well as facilitating development of coping strategies, relaxation, and distraction techniques, improving disrupted relationships, and development of skills and hobbies. In cooperation with social services, issues such as housing, finances, and employment can be addressed. Communication tip. People with emotionally unstable personality disorder, by definition, have difficulties forming and maintaining relationships, and that includes doctor-patient relationships. Misunderstandings and frustration are common on both sides. Remember to be calm, clear, and consistent, and try to take the long view. Do not let one difficult encounter dominate your relationship with the patient. About longer-term management. The long-term management of patients with emotionally unstable personality disorder involves addressing and modifying maladaptive traits of personality. This generally involves psychological therapy, because traits and behaviors tend to be deeply ingrained. This process can take many years. Around 40% of people with emotionally unstable personality disorder disengage with psychotherapy, and so it's important to build a trusting relationship and to be prepared for therapeutic change taking a long time. There is evidence suggesting the efficacy of various modalities of psychotherapy in the treatment of emotionally unstable personality disorder. It may be that the consistency of therapy, the maintenance of boundaries, and the empathic and non-judgmental stance of the therapist allows for the successful development of a therapeutic relationship, which may in itself be more important than the specific type of therapy. For more information on psychotherapy, see Chapter 3. The following psychological treatments can be helpful in emotionally unstable personality disorder. We have dialectical behavioral therapy, which uses a combination of cognitive and behavioral therapies with relaxation techniques and mindfulness. It involves both individual and group therapy and can be helpful in reducing self-harming and improving functioning. It is recommended by NICE 2009. Mentalization-based therapy focuses on allowing patients to better understanding what is going on in both their minds and in the minds of others. It can utilize both individual and group components. Cognitive behavioral therapy has been adapted for use as schema-focused therapy. Cognitive analytical therapy, psychodynamic psychotherapy as both individual and group therapy, which focuses on the relationship with the therapist. Therapeutic communities are a residential form of therapy where the patient may stay for weeks or months. The community tends to run as a democracy, with patients often having as much say as the staff. Most of the therapeutic work is done in groups, when patients learn from getting on or not getting on with others. It differs from real life in that any disagreements or upsets happen in a controlled and safe environment. These placements tend to be reserved for those with severe functional impairment or very high service usage because of their high cost. Hints and tips. Remember that personality disorders involve long-standing personality traits. While they are treatable, pharmacotherapy is not the mainstay, but is used to alleviate specific symptoms like comorbid depression, anxiety, or impulsivity. Medications are unlikely to affect maladaptive personality traits. With appropriate psychosocial interventions, these may significantly improve with time. You may want to consider this when discussing management with patients. Course and prognosis. The course of personality disorders and the prognosis of sufferers is not as dire as was once thought. Some 87 to 99% of patients with emotionally unstable personality disorder will show signs of sustained symptomatic remission at 16-year follow-up. Patients with antisocial personality may also improve with time, especially if they have formed a relationship with a therapist. Schizotypal and obsessive-compulsive personality disorders tend to be stable over time, although schizotypal patients may go on to develop schizophrenia. Patients with personality disorder have a greater incidence of other mental illnesses, such as depression, bipolar affective disorder, anxiety, and schizophrenia. Furthermore, these tend to be more severe and have worse prognosis than if the personality disorder was not present. Patients with personality disorder, especially cluster B, also have far higher rates of suicide and accidental death than the general population. Chapter summary. Personality disorders are common, particularly in users of health services. Comorbid mental illnesses are more frequent and difficult to treat in those with personality disorder. When managing emotionally unstable personality disorder, take a consistent, non-judgmental approach. Help the patient to make a crisis plan and share it with everyone involved in the patient's care. Symptoms can be improved by long-term psychological treatments such as dialectical behavioral therapy. Medication is only recommended in crisis and for comorbid mental illnesses. Personality disorders generally gradually improve over decades. That's it. هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.